Discuss the etiology, clinical features, investigations, and management of disseminated intravascular coagulation, that is DIC, consumptive coagulopathy. Disseminated intravascular coagulation, that is DIC, is a state or a syndrome characterized by widespread intravascular coagulation associated with increased consumption of platelet and clotting factors. TIC involves abnormal excessive generation of thrombin and fibrin in the circulating blood. During the process, increased platelet aggregation and consumption of coagulation factors occur. DIC produces both thrombosis and hemorrhage. DIC that evolves slowly over weeks or months causes primarily venous thrombotic and embolic manifestations. DIC that evolves rapidly over hours or days causes primarily bleeding. Etiology: DIC usually results from exposure of tissue factor to blood, initiating the coagulation cascade. DIC most often occurs in the following circumstances. First, infections. Second, severe tissue injury that can occur due to trauma, burns, or head injury. Third, cancer, particularly carcinoma of pancreas, prostate, and acute promyelocytic leukemia. Fourth, obstetric complications such as amniotic fluid embolism, HELLP syndrome, eclampsia, retained fetal products, septic abortion. Fifth, abdominal aortic aneurysm. Sixth, hemolytic transfusion reaction, that is ABO incompatibility. Seventh, snake bite. Eighth, fulminant hepatic failure. Pathogenesis. Normally, coagulation is mediated by thrombin and kept confined to a localized area by a combination of blood flow and coagulation inhibitors, especially antithrombin 3. When these mechanisms are overwhelmed by the markedly increased production of thrombin, thrombin may circulate and lead to disseminated intravascular coagulation. There is widespread deposition of fibrin leading to blocked blood vessels and tissue ischemia, consumption of platelets, fibrinogen, prothrombin, factor V, and factor VIII. Consumption of all these coagulant factors in turn may lead to bleeding. The major stimulus to thrombin activation in DIC comes from the tissue factor. Pathophysiology of DIC: increased release or expression of tissue factor lead to systemic activation of coagulation. This in turn causes two mechanisms. One is intravascular fibrin deposition, which leads to thrombosis of small and mid-sized vessels with organ failure. Second one, depletion of platelets plus coagulation factors that lead to the bleeding. Clinical features: DIC leads to both bleeding and thrombosis. Bleeding is more common than thrombosis. Bleeding may occur at any site, but spontaneous bleeding and oozing at venipuncture sites or wounds are important clues to diagnosis. Thrombosis is most commonly manifested by digital ischemia and gangrene. Other manifestations include dysfunction of liver, kidney, lungs, and central nervous systems. DIC also causes microangiopathic hemolytic anemia. Laboratory findings: hypofibrinogenemia, thrombocytopenia, and elevated fibrin degradation products. D-dimer is the most sensitive fibrin degradation product. PT is prolonged. APTT may or may not be prolonged. Peripheral smear shows fragmented RBCs due to microangiopathic hemolytic anemia. Antithrombin 3 levels may be markedly reduced. Treatment. Underlying cause of DIC should be treated. Replacement therapy. Platelets should be transfused to maintain a platelet count greater than 30,000 per microliter. Fibrinogen is replaced with a cryoprecipitate. Coagulation factor deficiency may require replacement with fresh frozen plasma. When there is excessive fibrinolysis, EACA 1 gram intravenously per hour may be tried in combination with heparin. EACA, that is epsilon aminocaproic acid, should not be used without heparin in DIC because of the risk of thrombosis. Antithrombin 3 replacement has not been shown to reduce mortality rate of severe sepsis with DIC. However, one trial has shown benefit by the use of activated protein C. The role of heparin in the treatment of DIC is controversial. Clearly, it is contraindicated before or after neurosurgical procedures. Heparin is useful in slowly evolving DIC which presents primarily with thrombosis. It is also useful in the presence of thrombosis or fibrin deposition leading to acral cyanosis. Heparin is usually not indicated in rapidly evolving DIC with bleeding manifestations except in women with a retained dead fetus and evolving DIC with a progressive decrease in platelets, fibrinogen, and coagulation factors. A dose of 500 to 750 units per hour of heparin is enough in DIC, and APTT need not be prolonged for clinical benefit. Heparin is not effective if antithrombin 3 levels are markedly reduced. If antithrombin 3 levels are very low, it can be raised by giving fresh frozen plasma or antithrombin 3 concentrates.